Good day, everyone. My name is Gail Afra C. Larino, and today I will be discussing CLO number 7, or to explain the scientific principles involved in the performance of advanced life support, or ALS. So, the first scientific principle is anatomy and physiology. So, the rescuer must be knowledgeable in the anatomy and physiology of the human body in order to properly administer advanced life support, such as knowing the proper placements of defibrillation, proper placement of the trachea for airway management, and where to administer medications. The second scientific principle would then be body mechanics. So the rescuer must position themselves in proper body mechanics to prevent injury to the patient and to themselves. Also, the rescuers performing body mechanics also decrease the chances of straining themselves. The third one would then be microbiology. There must be basic knowledge of microbiology in order to prevent the spread of infectious diseases to other people. There must be a use of gloves when performing procedures such as airway management, as bodily fluids may be transmitted. And lastly, proper hand hygiene must also be performed before and after the performance of ALS. Next would then be pharmacology. So the healthcare provider must be knowledgeable on what medications are administered for ALS in order to prevent overdose or administering the wrong drug. The rescuer should know the mechanism of action, indications, contraindications, possible side effects of the medication, possible adverse effects, drug interaction, and its route of administration when administering the drugs for advanced life support. So next would then be physics. So most current defibrillators are energy based, which means that the device charges a capacitor to a selected voltage and then delivers a pre-specified amount of energy in joules. The amount of energy which arrives at the myocardium is dependent on the selected voltage and the transthoracic impedance, which varies by patient. So, a defibrillator only works if a ventricular fibrillation or a ventricular tachycardia is detected. It depolarizes the entire heart system to repolarize and return the heart to a normal electrical activity. So, if the shock is not strong enough, the heart might not completely repolarize, leading to an arrhythmia, making a strong electrical current or shock necessary for defibrillation. So next would then be psychology. In performing advanced life support on a patient can be anxiety-filled and scary for the patient's family. Psychology is involved in the performance of ALS because it is important to break bad news in an empathetic and grief facilitating way to family members. Psychology is also necessary for the healthcare workers as it is important for the emergency workers to attend to their own feelings and health, for example, in critical incident debriefing. Next would then be safety and security. So, safety and security is involved in performing advanced life support by how the equipment used needs to be checked frequently to make sure they are working when they are in need. The healthcare workers must check the devices beforehand in order to prevent the patient's condition from possibly worsening due to a faulty device. Next would then be sociology. So the nurse should build a rapport with the patient and the patient's family in order for them to trust the nurse. Patients who are suspected to need advanced life support will need to be handled with extra care, so the nurse must know how to communicate with the client while anticipating their needs. And lastly, time and energy. Having the necessary materials prepared beforehand allows for a smooth flow of the advanced life support. Advanced cardiac life support, pediatric advanced life support, and advanced trauma life support needs to be done in a prompt and quick manner so the patients are treated efficiently to prevent the worsening of their conditions. And that is the end of my part. Thank you, everyone.
Hello everyone, my name is Mara Matulak and I'm gonna report the CLO number 8, which is to discuss the medical emergency situations that needs ALS. for our first situation, the ALS is needed when there's an insufficient basic life support and immediate life support treatment which requires further intensive and critical care intervention from a more highly trained emergency care practitioner. So if the patient, which the EMT or the emergency medical technicians feels that requires ALC care, the BLS and the ILS should refer it to ALS. If there's a cardiac arrest patient, also both the BLS and the ILS should refer it to advanced life support. So for the cardiac patient, if the patient is hemodynamically unstable or has chest pain unrelieved by their own nitro and oxygen, the BLS should refer it to ALS. For trauma patient, if there's a blood loss of more than 500 cc in an adult and 8 cc per kilogram in children, hemodynamically unstable, any degree of respiratory distress, any third-degree burn, second-degree burn to more than 10% of body surface, or involving the face, and any electrical burns, the BLS should refer it to the ALS. For the medical patient, both BLS and ILS ambulance should refer it to ALS if there's any life-threatening medical emergency that can be treated with drugs and or equipment available only on an ALS ambulance. For example, volume for a patient seizing or patient with seizure. For pregnancy, the BLS should refer it to ALS if the patient is in active labor or presents with significant vaginal bleeding. So for the ILS, for the cardiac patient, if the patient is hemodynamically unstable, has chest pain unrelieved by nitro and oxygen, or has life-threatening arrhythmias, this patient should be referred to ALS. If unable to establish and maintain an airway, any trauma patient who needs pain control, the trauma patients should be referred to ALS. And for the pregnancy, so any patient in active labor under the ILS ambulance, this should be referred to ALS. For the second medical emergency, we have airway obstruction. So airway obstruction can be complete or partial. When we say complete airway obstruction, it rapidly causes cardiac arrest. As for partial obstruction, it precedes complete obstruction. So in partial obstruction, it can cause cerebral or pulmonary edema, exhaustion, secondary apnea, and hypoxic brain injury, which eventually leads to cardiac arrest. Also, when there's a central nervous system depression, it may cause loss of airway patency and protective reflexes. Causes include head injury, intracerebral disease, hypercarbia or increased carbon dioxide in the bloodstream, the depressant effect of metabolic disorders such as diabetes mellitus, and drugs including alcohol, opioids, and general anesthetic agents. For the treatment of airway obstruction, we have to give oxygen as soon as possible to achieve an arterial blood oxygen saturation by pulse oximetry in the range of 94 to 98%. Also, we can perform simple airway opening maneuvers such as head tilt chin lift or jaw thrust, insertion of an oropharyngeal or nasal airway, elective tracheal intubation or tracheostomy may be required. Also, there's a consideration in the insertion of nasogastric tube to empty the stomach. For the third medical emergency, we have breathing problems. So breathing inadequacy may be acute or chronic. It can be continuous or intermittent and severe enough to cause apnea or respiratory arrest, which will rapidly cause the cardiac arrest. So respiratory arrest often occurs because of a combination of factors. For example, in a patient with chronic respiratory inadequacy, a chest infection, muscle weakness, or fractured ribs can lead to exhaustion, further depressing the respiratory function. So, if breathing is insufficient to oxygenate the blood adequately or causing hypoxemia, a cardiac arrest will occur eventually. For the treatment of breathing problems, we have to give oxygen to all acutely ill hypoxemic patients and treat the underlying cause. Patients who are having difficulty breathing or are becoming tired will need a respiratory support. Non invasive ventilation using a face mask or a helmet can be useful, and prevent the need for tracheal intubation and ventilation. And for patients who cannot breathe adequately, sedation, tracheal intubation, and controlled ventilation are needed. So for the last medical emergency, we have circulation problems. It may be caused by primary heart disease or by heart abnormalities secondary to other problems. Most often, circulation problems in acutely ill patients are due to hypovolemia. The heart may stop suddenly or may produce an inadequate cardiac output for a period of time before stopping. So let's talk about the primary heart problems first. So the commonest cause of sudden cardiac arrest is arrhythmia caused by either ischemia or myocardial infarction. Cardiac arrest can also be caused by arrhythmia due to other forms of heart disease, by heart block, electrocution, and some drugs. Sudden cardiac arrest may also occur in cardiac failure or cardiac tamponade, cardiac rupture, myocarditis, and hypertrophic cardiomyopathy. For the secondary heart problems, the heart is affected by changes elsewhere in the body. For example, cardiac arrest will occur rapidly following asphyxia from airway obstruction or apnea, tension pneumothorax, or acute severe blood loss. Severe hypoxia or anemia, hypothermia, oligemia, and severe septic shock will also impair cardiac function and may lead to cardiac arrest. The main goal of the treatment is to treat the underlying cause of circulatory failure. In many sick patients, this means giving intravenous fluids to treat hypovolemia. Survivors of an episode of ventricular fibrillation are likely to have a further episode unless preventative treatment is given. These patients need percutaneous intervention, coronary artery bypass grafting, or an implantable defibrillator. Cardiovascular support includes correction of underlying electrolyte or acid-base disturbances and treatment to achieve a desirable cardiac rate, rhythm, and output. Advanced cardiovascular monitoring and echocardiography may be indicated. Appropriate manipulation of cardiac filling may require fluid therapy and vasoactive drugs. Inotropic drugs and vasoconstrictors may be indicated to support cardiac output and blood pressure. In some situations, mechanical circulatory support, like for example the intra-aortic balloon pump, or consideration of heart transplantation will be necessary.
So good day, my name is Rachel Pahante and I'll be discussing CLO number 9, the qualifications of an ALS provider. So how does one apply for ALS provider to become an ALS provider? So first and foremost, they have to have received a bachelor's degree of an higher education. So they have to be registered medical professionals. Um, For the candidates who have reached the required standard to receive they receive an ACLS provider certificate or advanced cardiovascular life support provider certificate. So the certification is valid for 2 years. So for the initial certification, it consists of a 2-day course that includes a written and practical exam. So for the recertification, it may be completed in a condensed 8-hour course. So what organization does the certification? So an example of an organization that um, provides the certification can be the Red Cross. It can also be for example, we have the American Heart Association. So the candidate's knowledge is assessed by means of a multiple choice question paper. The practical skills, there's also a test in the practical skills in airway management and the initial approach to a collapsed patient. So this includes the basic life support and defibrillation. So these are continuously assessed and they are also updated based on the standard of care that was previously learned. Oh no, pre- uh, what what they have previously learned will be updated on the standard of care that is present if there are changes. So there's also an assessment of a stimulated cardiac arrest test. So this course comprises workshops, skill stations, lectures, and the CAS training or the cardiac arrest stimulation training. So, and not to forget, an exam and testing will follow to be able to evaluate the learnings of the learner. So, what are the skills learned for the ALS provider course? So they should be able to recognize and treat a deteriorating patient using a structured ABCDE approach or the airway, breathing, circulation, disability, and exposure. So they also should be able to deliver standardized CPR in adults, manage a cardiac arrest by working with a multidisciplinary team in an emergency situation, while using non-technical skills to facilitate strong team leadership and effective team membership. So these individuals have to learn to work with each other to be able. It requires team effort to be able to carry out the procedures effectively and properly. So, who are the appropriate applicants? So this includes um, doctors, nurses, well, especially those working in critical areas such as the emergency department, the CCU or the coronary care unit. We also have the intensive care unit. We also have the high dependence unit. So high dependence, um, the staff are equipped to provide a level of care that is that is intermediate between an intensive care unit and a general ward. We also have operating theaters, so professionals that are assigned in the OR. We also have acute medical mission units. We also have the paramedics. We also have the outreach teams or in the resuscitation medical emergency team. And that is it for my report on the requirements or qualifications of an ALS provider.
Everyone, my name is Ben Wilfred Pinales, and together with me is Miss Kiana Pamalos, and we will be reporting CLO number 10, which is the guidelines in performing ALS. So this is the adult cardiac arrest algorithm. So when performing ACLS, first you start with CPR. Give oxygen to the patient, then you attach the monitor and or defibrillator. If it presents rhythms such as ventricular fibrillation or pulseless ventricular tachycardia, then you initiate ACLS protocol right away. Determine if patient is asystole or PA or pulseless VTAC or VFib. If it presents shockable rhythms such as VTAC or VFib, shock the patient, then initiate CPR for 2 minutes while you perform and maintain IV and IO access. Prepare defibrillator. Shock the patient again. If there is no electrical activity, then back to CPR. Prepare epinephrine to be infused every 3 to 5 minutes while considering advanced airway and or capnography. If it still presents rhythms such as ventricular fibrillation or pulseless ventricular tachycardia, then initiate shock to the patient one more time. Prepare amiodarone or lidocaine to be administered while you treat reversible causes as possible. Repeat cycle one more time if it still presents shockable rhythm. If not, look for signs of return of spontaneous circulation. If no signs of return of spontaneous circulation, then you go back to steps 10 or 11. But if there is a return of spontaneous circulation, then proceed to post-cardiac arrest care and consider appropriateness of continued resuscitation.
Good day, everyone. I'm Ms. Pamalas, and I'll be continuing the discussion for CLO number 10, which is the guidelines in performing ALS. So we have here the adult cardiac arrest algorithm. So I will proceed in discussing the right side of the illustration. So after starting the CPR, we then give oxygen and attach the monitor or defibrillator. We then check whether there is a pulse rhythm and whether it is shockable or not. So if not, this is a asysto or a pulseless electrical activity. We then proceed in administering of the epinephrine as soon as possible. We then continue in providing the CPR under 2 minutes and then IV IO access and consider the advanced airway capnography. We then check again the rhythm of the pulse, if it's shockable or not. If yes, we then proceed to box 5 which is to perform the defibrillation to the patient. If not, then we perform CPR again and treat reversible causes. We then check whether the pulse rhythm is shockable or not, and then if no signs of return for spontaneous circulation or ROSC, then we proceed in box 10 or 11, which is to perform again the CPR to the patient. If ROSC go to a post-cardiac arrest care, we then consider the appropriateness of continued resuscitation. If yes, the rhythm is shockable, we then proceed to box 5 or 7, which is to perform defibrillation to the patient. So that ends our discussion.